Hello, I'm Pablo Molina, a radiology resident from the Caribbean Islands, and currently studying in Saint-Antoine Hospital in Paris. So, the following case about a man 60 years old with chronic headache and recently relapsed in Roma and a hoarse voice. So I'll let you think about following radiographic features, and there are lots, so we need to speed up. So here you have the 2T weight high resolution images. Okay, here you have the T1 announced images. And finally, axial T1 announced slice with a sagittal correspondent image. And eventually the bone reconstruction on CT scan. Okay, so what is it about? Well, it's it's quite simple. You gotta tell me. So we have a well-defined thing on the path of the vagus cranial nerve. We spoke about before. So with a high T2 signal and intense homogeneous announcement. And we can now speak about the schwannoma, which is the cause of the widening on the left jugular foramen on the CT scan. And this schwannoma is actually quite aggressive, since there is a bone reaction contacting the growing tumor. A quick reminder about schwannomas. It's a mild tumor which affects the vestibular nerve in 90% and represents 5 to 8% of all cerebral tumors. On the CT scan, you have a normal to high density lesion without calcification and with frequent widening of cranial base foramen on its way. On MRI, you have a normal T1, high T2 signal, and normal diffusion, and a strong announcement, which is more often homogeneous than heterogeneous. Only 2% are intracranial, and in this case, they appear as a combination of cystic and solid lesion with sometimes calcification. If you find more than one schwannoma, then think about neurofibromatosis number 2. This malignant conversion, is extremely rare, and post-surgery recurrence is below 10%. So, by the way, here you have the schwannoma differential diagnosis. So the main differential diagnoses are meningioma, which is more homogeneous and with calcification, broad dural base, and then you have the epidermoid cyst with high diffusion and restriction on ADC and without announcement. And then you have the glomus tumor with microhemorrhage on T1, flawois on T2 and vascular blush. You have chondrosarcoma with a high T2, calcification and heterogeneous announcement, and is often quite aggressive. And cholesterol granuloma with high T1, high T2, no announcement, and sometimes aggressive. So, by the way, in our case, what is about the T1 without announcement? So, in truth, we have a well-known expression, be careful with the tree hiding the forest. So just don't stop on the obvious and let's have a complete reading. So here you have the last sequence, the T1 with gradient ecomage without announcement. Okay. So, what you find about this? So this is a melanotic schwannoma. This is an exceptional lesion, as we only count 150 cases reported. It appears as a high T1 wasted schwannoma, and the differential diagnosis arguments against melanotic metastasis are young patient with no primary melanoma and a frequent cystic structure with a typical hourglass shape extension through cranial or spine foramens. And the treatment is based on surgery and check-out, since there is a significant risk of malignant transformation, which is not the case of common schwannomas. The final diagnosis is based on biological features as the psammoma bodies, and here you have So here you have an example of a Schwannoma body. So what's the take-home reminder? First, it's important to check the spontaneous T1 signal. Second, you cannot do the diagnosis on the MRI, so watch out with your conclusion. But you have the responsibility to call attention on an unusual schwannoma, which must lead to additional exams and then the final diagnosis. So after the diagnosis is done, you also have a prime role to screen the malignant transformation. Okay, so yeah, prepared a quick quiz, but I don't know if we have time for it. So before we break up, as I know you love it, I have prepared a quick test about the cranial foramens. So you need to know this anatomy since it's really useful for traumatism and otorhinolaryngous tumors, etc. So the first one is quite simple, just to make you feel confident, of course. So it's the Magnus foramen. So now let's do it more difficult. So number one, it's the pterygopathon fossa. Number two, the lacerum foramen, which is actually not the true foramen. Number three, this is a tympanic proboscis. We call it the trompe d'Eustache. Number four, it's the carotid channel, intrapetrous carotid. And then number five, vestibular aqueduct. Number six, number six is the infraorbitary foramen. Number seven, the sphenopalatine foramen, also called Witten channel. Number 8, oval foramen. And number 9, epinous foramen. And number 10, should you guess? So it's not a foramen, this is a temporomandibular joint. Now you have a frontal view of pterygopathon fossa with number 1, the optic foramen. Number 2, the superior orbital rift. Number 3, the inferior orbital rift. And number 4, the sphenopalatine foramen. And here you have an explanatory slide about the pterygopathon fossa, which is an important communication between the face and the brain, and then is a common way of extension for facial tumors. Okay, so thank you very much.